So welcome back to Travis County ESD1 Continuing Education for 2021. Travis Garrison will be teaching a course on cardiac anatomy and electrophysiology. It's scheduled for 1 hour. I suspect he'll go over because that's a lot of stuff to cover in an hour. It's going to be good for about an hour and a half with a CE. To get your CE, you have to watch the entire video, take the test and the evaluation, and send them to me at tkinney@tcesd1.org. I have to be able to verify that you watched the video, and currently the only way that I have to do that is for me to be on with you. So we'll be showing this video today, Wednesday, and Friday at 10 a.m., and I'll be on with you, so it counts as guided learning. Beyond that, we have to figure something out, so just email me and we'll start the conversation about how to do that. It is being recorded, so be careful. If you have any questions, please either put them in the text box or just unmute yourself and ask away. That being said, Travis Garrison, the very famous and excellent instructor.
All right, welcome everybody to cardiology. TK said I'm going to be going over some A&P and electrophys, some rhythms, and then we'll go over just some of the protocols that we have. We have quite a few protocols that actually deal with cardiac issues. So we don't just have one or two. There's quite a few, and so we'll just kind of touch on those. But bear with me. This is going to be a lot of information. I'm going to kind of breeze through a lot of it. There will be some things that I'll slow down and get into pretty good detail with, but a lot of it is just going to be kind of breezing through. All right. TK, is the PowerPoint showing up? I guess it is. Yeah. All right. So we'll jump into cardiac anatomy and electrophysiology. All right. So different parts of the heart. So the heart itself is about the size of your fist, right? And the bottom of the heart is considered the apex, which lies just above the diaphragm. And the top of the heart is the base, and it lies at the level of the second rib. All right, there's 3 layers that are part of the heart. You have the innermost layer, which is the endocardium. You have the thick muscular middle layer that has some skeletal muscle with electrical properties. That's the myocardium. And then the pericardium is the protective sac that surrounds the heart, and it's got 2 layers. Okay, it's got the visceral and the parietal layer. So the visceral pericardium, that's the inner layer and is in contact with the heart muscle itself. And then just on the other side of that is the parietal pericardium, which is the outer, real fibrous layer. And in between those 2 layers is what we call the pericardial fluid. And this is what kind of reduces the friction as the heart contracts and expands. Okay, contracts and retracts, so it doesn't stick. Okay, similar to your visceral and parietal layer and fluid with your lungs in the thoracic region. All right, so we got 4 chambers in the heart. All right, you got your right and left atria, which are the 2 chambers that are the superior part of the heart, and those receive incoming blood. And then you have the right and left ventricles, which are the 2 inferior chambers of the heart, and those are responsible for pumping blood away from the heart. All right. The heart contains 2 pairs of valves. You have the atrial ventricular valves, which control blood between the atria and the ventricles. The right valve is called the tricuspid valve, and the left valve is called the mitral valve. All right. These valves, they're connected to papillary muscles in the ventricles. All right. Oops. right, you also have the semilunar valves, which regulate blood flow between the ventricles and the arteries. The left semilunar valve, that's called the aortic valve, and this connects the left ventricle to the aorta. All right, so when the left ventricle is pumping blood to the rest of the body, it's got to pass through the semilunar valve into the aorta, and then from there it goes up and down through the body. Okay. The right semilunar valve is called the pulmonic valve, and this valve connects the right ventricle to the pulmonary artery. Okay, so this is the part of the heart where the deoxygenated blood is in the right ventricle and is pumped through the right semilunar valve into the lungs to become oxygenated. All right. So how does the blood flow? Blood flows through the heart when it enters the right atrium from the superior and inferior vena cava. All right, the superior vena cava gets deoxygenated blood from the head and upper extremities, and the inferior vena cava gets the deoxygenated blood from the areas below the heart. All right, the right atrium then pumps blood through the tricuspid valve into the right ventricle. The right ventricle then pumps through the pulmonic valve, which we just talked about, into the pulmonary artery, where it flows into the lungs, and it picks up oxygen, but it also releases carbon dioxide. All right, and that's when we get into the breathing. We get the oxygen in, and we release the carbon dioxide out. Blood then returns via the pulmonary veins into the left atrium, and the left atrium pumps through the mitral valve into the left ventricle, at which point the left ventricle will pump through the aortic valve into the aorta, where it is moved through the body, the head, and then everything below the heart. All right. Coronary circulation for the heart muscle itself originates in the aorta, just above the leaflets for the aortic valve. The left coronary artery, the anterior descending artery, the circumflex, the RCA or right coronary artery, marginal artery, and posterior descending artery all receive blood during diastole. Okay, so when the heart relaxes, this is when those arteries fill with blood to supply oxygen to the heart itself. Excuse me. Sorry. Okay. So anatomy, the peripheral circulation. The peripheral circulation transports oxygenated blood from the heart to the tissues and deoxygenated blood from the tissues to the heart and lungs. Okay, we just kind of briefly touched on that. The arterial system carries oxygenated blood and functions under high pressure. The arteries actually then branch into arterioles and finally terminate at the capillaries. The venous system is very similar. However, it transports deoxygenated blood under low pressure with help from surrounding muscles and one-way valves. Similar to arteries that branch into arterioles and then capillaries, the venous system, actually the capillaries branch into venules, which branch into veins before ending at the inferior and superior vena cava. All right. So that's that right there is a little bit of the anatomy, a little bit of physiology. We're going to continue more into the physiology now, the mechanical and the electrical. So let's talk. We're going to talk about the cardiac cycle. All right. So the cardiac cycle is the sequence of events that occurs between the end of one contraction and the end of the next. All right, so diastole is actually the first phase of the cardiac cycle, and it's known as the relaxation phase. It's kind of counterintuitive. We tend to think that when something squeezes, when it contracts, that's like the first stage. Okay, but actually the first phase is diastole. Okay, so this is when ventricular filling begins as the muscle is relaxed. Okay, blood is entering into the ventricles from the atria. And this is also when the pulmonic and aortic valves close, so no more blood can enter or can go out to the body or into the lungs. Okay, because those valves close shut. Systole is the second phase, and this is when the heart contracts. Okay, so the atria contract quickly, and just before the ventricles, the blood will flow out of the ventricles through the pulmonic and aortic valves. The mitral and tricuspid valves close, preventing blood from backflowing into the atria. The normal ventricle ejects about 2/3 of the blood it contains. Okay, this is what we call stroke volume. All right. This ratio, the 2/3 of the blood, that ratio, we call that ejection fraction. Okay, so say that again. The amount of blood that's that the ventricles eject, which is about 2/3 of its volume, that's stroke volume. Okay, that ratio, that 2/3 ratio, that's called the ejection fraction. All right, so stroke volume, which is the amount of blood ejected from the amount that the chamber has, okay, depends on 3 factors. All right, preload, or also called end diastolic volume, and that's the pressure in the ventricle at the end of diastole. So as soon as the ventricle is relaxed, okay, that pressure right there, okay, that's what the preload is, okay. Second thing of the 3 factors, cardiac contractility is dictated by Starling's law. Excuse me. Starling's law states that the more myocardial muscle is stretched, the greater the force of the contraction will be, up to a limit. Okay. Part of that law states that basically it can't stretch infinitely. Okay, there is a limit to it. The third thing, afterload, that's the resistance that the ventricles pump against. Okay, say that again. Afterload, that is the resistance that the ventricles must pump against to get the blood out. Okay. All right, cardiac output, that's the volume of blood pumped in 1 minute. Okay, cardiac output is the volume of blood that is pumped in 1 minute, or 60 seconds. So how do you calculate that? Cardiac output simply is your stroke volume, how much blood that you have that's being ejected, times your heart rate. Okay? All right, nervous control of the heart. The sympathetic and parasympathetic components of the autonomic nervous system work in opposition to regulate the heart. All right, so during stress, the sympathetic nervous system becomes dominant. It innervates the heart at the cardiac plexus. Norepi is the neurotransmitter that increases the heart rate and cardiac contractility. Your alpha receptors that are located in the peripheral blood vessels, so your periphery, are also responsible for vasoconstriction. Beta-1 receptors in the heart's increased rate in contractility. Beta-2 receptors in the lungs, as well as peripheral blood vessels, cause bronchodilation and peripheral vasodilation. Okay, that's all the sympathetic nervous system. Okay, the parasympathetic control of the heart occurs via the vagus nerve, which runs along here. Okay, the parasympathetic neurotransmitter is acetylcholine. This slows the heart rate and atrioventricular conduction. All right. There's three terms we talked about when we refer to the heart function. That's chronotropy, inotropy, and dromotropy. Okay, chronotropy, chronos refers to the heart rate. Chronos, you probably have on your watch something that says chromograph, something like that. So chrono usually means time. So you're talking about chronotropy or tropy, it refers to the heart rate. Inotropy refers to the strength of the contraction. And then dromotropy refers to the rate of nerve's impulse conduction. All right. Let's see. All right, so we have different types of cells that are in the heart. Primarily, there are myocardial cells and pacemaker cells, but there's also some musculoskeletal cells inside the heart. But that gets into more of the, what is it called? The SR reticuli contains a bunch of calcium in the heart. We'll get to that in a minute. But anyway, so the primary cells that are in the heart are going to be your myocardial cells, or your contractile cells, and your pacemaker cells. They're all myocytes. They're all myocardial cells, but they have certain jobs. For instance, they all start out, when the heart is developed, they all start out as myocytes. When certain cells become pacemaker cells, they lose their ability to become contractile cells. And so their sole responsibility is just to basically conduct electricity via change in polarity, positive and negative, by way of electrolytes. Okay, electrolytes play a huge role in our heart function. Most of the electrolytes that are in the heart that contribute to heart function is going to be calcium ions, sodium ions, potassium ions, some magnesium ions, so sodium, potassium, calcium, magnesium, and I think chloride. That's about it. But the main ones are going to be sodium, calcium, and potassium. Let's see. All right, automaticity. This just simply talks about, or means, it's the ability of cardiac pacemaker cells to create an electrical impulse without being stimulated by another source, such as the brain. So, technically speaking, the heart can function to a degree. It can create impulses. It can create its own thing without getting information from the brain to do so. Okay, it all has to do with the polarity of certain ions inside and outside of the cell and the interstitial fluid. All right, so let's talk about. I'm gonna spend a little bit of time on this: the cardiac action potential, resting membrane potential. I know this stuff can get a little confusing, but I feel if you can really get a good grasp on how this system works and how the electrolytes play a role in cardiac function, it will also help us in understanding how, like, calcium channel blockers work, or beta blockers, right? How some of these medicines or medications, how they work and why they're used. All right. So, let's see here. So cell membranes contain membrane channels, like we just talked about, calcium channel blocker, right? It blocks a calcium channel because there are actually channels that are in these myocytes. All right. All right. So let's talk about pacemaker cells. All right. Pacemaker cells, they connect to contractile cells through what's called gap junctions. All right. These form channels that allow ions to flow from one cell over to another. All right. This allows electrical coupling of neighboring cells. An action potential in one cell then triggers an action potential in its neighbor, and then the signal begins to propagate rapidly. Okay, it's almost like a domino effect. All right, or like if you've seen a slowed down video of lightning where the lightning begins here and then it just quickly just spreads all across the sky. Very similar to how the pacemaker cells interact with the contractile cells, and once that process begins, and it propagates quite quickly as it continues on. Okay, so as it begins in the SA node, the sinoatrial node, okay, the impulse will reach the AV node, the atrioventricular node, where they will then slow down slightly, and this allows the atria to contract, okay? And then it will follow the conduction pathway and spread through the ventricular myocytes. All right? A couple things, or one thing to notice, or to note, pacemaker cells, those are autorhythmic. Contractile cells are non-autorhythmic. Okay. All right. So resting membrane potential. All right. The process of the resting membrane potential slightly differs between your pacemaker cells and your contractile cells. Okay. We're going to talk a little bit about both. All right, so outside the cell, we're first going to talk about the pacemaker cells. Okay, at its rest, when there's no activity going on, typically outside of that cell is more positive, and inside of the cell is more negative. Okay, so generally, the resting cells have a negative charge. Okay. There's more sodium and calcium ions outside of the cell, and there's more potassium ions that are inside of the cell. These gradients are maintained by several pumps along the membrane that bring sodium and calcium out and potassium in. Okay. And action potential is essentially it's a brief reversal of electrical polarity of the cell membrane. Okay, that's all it is. All right, so what happens? All right, this is produced by voltage-gated ion channels that are on the membrane. These channels then they're basically passageways for ions to go in and out of the cell. Okay. And as the name suggests, they're regulated by membrane voltage. Okay, so they open at some values of membrane potential and then they close at others. Okay, so when membrane voltage increases and becomes less negative, the cell is less polarized. So it's said to be depolarized. Conversely, when the cell becomes more positive, it is then repolarized. For an action potential to be generated, the membrane voltage must depolarize to a critical value called the threshold. All right. So all of that I just talked about is the same, actually, for pacemaker cells and contractile cells. Here's where it gets a little bit different. So pacemaker cells don't have a true resting membrane potential, but they have a similar one. Okay, so at rest, your pacemaker cells sit at about negative 60 millivolts. It increases up to negative 40 millivolts, and in pacemaker cells, negative 40 is the threshold that we just talked about. Okay, there's going to be a slight difference between these number values when we get into the contractile cells. All right, so when voltage is less than negative 40 millivolts, a slow influx of sodium ions enter the cell. Okay, it's a slow process. This is what gradually increases from 60 to 40 to that threshold. Okay, this is the pacemaker potential. Okay, once the threshold is reached, which is negative 40 millivolts, the calcium channels open allowing the calcium ions to flow into the cell. Okay, when this happens, it further depolarizes the membranes. This results in the rising depolarizing phase of the action potential. At the peak of the depolarization, potassium channels now open. Calcium channels become inactive, and calcium ions leave the cell, and the voltage returns to negative 60 millivolts. Okay, this corresponds with the falling or repolarizing phase of the action potential. The original ionic gradients are then restored thanks to the several ionic pumps, and the cycle starts over again. Okay, so that's how your pacemaker cell operates or functions electrically. Okay, so how does that differ from action potential of contractile cells? A little bit different. So contractile cells are stable at a resting potential of negative 90 millivolts. Okay, remember the pacemaker cells was negative 60. Contractile cells resting potential is negative 90 millivolts, and depolarize only when stimulated. Okay, so if they're not stimulated, then they're just going to hang out at negative 90 millivolts. Okay, and they're not going to do anything. Okay, it has to have an outside stimulation in order for it to begin its process. It gets that from the pacemaker cells. All right. And as we talked about, the propagating rapidly beginning at one point, when the pacemaker cell, the last pacemaker cell touches the first contractile cell, then that stimulation from the contractile cell to its neighbor will kick off that stimulation. So it's not that all contractile cells have to be stimulated by a pacemaker cell. All right. Most of them begin their process because they are stimulated by their neighbor. Okay, which at one point began with a contractile cell being next to a pacemaker cell. Okay. All right. So when a cell is depolarized, there is more sodium and calcium inside the cell. The positive ions leak through the gap junctions to the adjacent cell. Okay, so it's moving parallel. We're not talking about in and out of the cell into the extracellular fluid. Okay, we're talking about neighbors. Okay, positive ions leak through the gap junctions to the adjacent cell, and they bring the voltage of the cell up to negative 70 millivolts, or the threshold. Okay, so pacemaker cells begin at negative 60 millivolts. Their threshold is negative 40 millivolts. Contractile cells, their resting is negative 90 millivolts. Their threshold is negative 70 millivolts. Okay, at threshold for contractile cells, once threshold is reached, then fast sodium channels open, creating a rapid sodium influx and a sharp rise in voltage. Okay, this is the depolarizing phase. Slow calcium channels also open at negative 40 millivolts, and this creates a slow but steady influx of calcium ions. Okay. As the action potential nears its peak, sodium channels close quickly, and then voltage-gated potassium channels open, and these result in a small decrease in membrane potential. Okay, this is what we call early repolarization phase. At that point, the calcium channels remain open, and the potassium efflux. All right, so you have influx and efflux. So influx, everything's coming in. Efflux is coming out. So at that point, calcium channels remain open, and the potassium efflux is eventually balanced by the calcium influx. Okay, so as potassium is leaving, calcium is coming in, and they start to balance each other. Okay, this keeps the membrane potential relatively stable for about 200 milliseconds. Okay, this is what we call the plateau phase. All right. This is the phase where you're going to get the majority of muscle contraction. All right, and the reason why it lasts a long time, 200 milliseconds, is because it takes time for muscle to actually contract and then release. All right, so that's what we call the plateau phase. Here, calcium is, well, we should know this, but calcium is crucial in coupling electrical excitation to physical muscle contraction. All right, the influx of calcium from the extracellular fluid as it's coming into the cell, it's not enough to induce contraction, but what it does is it triggers a much bigger calcium release from the SR, sarcoplasmic reticulum, sarcoplasmic reticulum, which basically houses a boatload, a crap load of calcium. Okay, so as that calcium's coming in from the extracellular fluid, it stimulates the SR, the sarcoplasmic reticulum, to release a whole bunch of calcium. At this point, the calcium then sets off muscle contractions by the same sliding filament mechanism described for skeletal muscle. All right. The contraction starts about halfway through the plateau phase and lasts until the end of the phase. All right. As calcium channels slowly close, then potassium efflux predominates. So potassium's flowing out of the cell. And then membrane voltage returns to its resting value at negative 90 millivolts. Calcium is actively transported out of the cell and also back to the sarcoplasmic reticulum. The sodium-potassium pump then restores the ionic balance across the whole cell membrane. All right, and then basically the whole process starts over again. Got it? Good. So here's a picture or kind of a graph, cardiac action potentials in your ventricle, the atrium, the SA node. Should have had it on this screen as I was describing it so you could see the different phases. Here's your refractory period. You can see here, this is that plateau phase that I was talking about. Okay. All right, the conduction system. So everything in a healthy, normal heart, the pacemaker is your SA node, sinoatrial node, then goes to the AV node, which then goes through the bundle of his to the right and left bundle branches to the Purkinje fibers. Okay. We know that if it is a normal heart with SA node begins that the SA node begins the impulse, then you're going to look at heart rates between 60 to 100 beats per minute. Okay, if the heart rate originates in the AV node, it's going to be between 40 and 60, and then if it's anything under that, it's usually between 20 and 40. Okay. All right. We want to take a break. We'll take 5 minutes. We'll get into ECGs. We'll do that. Take a 5-minute break. And we'll get into ECGs.
Not yet. I haven't answered. I'm just doing Yeah, that's fine. Yeah, 'cause I was supposed to move them over, but I didn't have my laptop and we went out of town. So
Kind of miss the detail.
well, we got all of our new stuff in, so there's furniture in every room, but we still don't have water. Like the plumber had to fix the showers and took us the hot water, so get it out, can't move in. Oh my God, and we got cable yesterday, last night, the dish was there till, shit, I think it was 11 o'clock last night. So we have TVs over there too, so it's like, yeah, I love to be there. Yeah. For like move-in day, or what, you know? Because we'll move in as soon as he hooks up the hot water. The word is right next door, so. Lainey said you guys will do taking over the stuff that she doesn't use, like her shorts and stuff like that, start putting it in the dresser. Go for it, because, I mean, yeah. So, hopefully by next weekend, we'll see, the plumbers are, oh, so, okay, I will, thank you.
All right, welcome back. Okay, let's see. All right, so ECG, right? We have it, we use it. We can find out a lot of things from it. We can do 4 lead, 12 lead, 15 lead, 18 lead. But basically, ECG, it amplifies impulses and then records them over time on paper, okay, or screen. We're looking at the screen. All right, negative impulses deflect downward. Positive impulses deflect upward. The absence of any electrical impulse produces an isoelectric line. Okay, just a straight line. And then artifacts, things that aren't related to the heart, are produced by things other than the heart's electrical activity. All right, ECG leads are a pair of electrodes placed in various places on the body. The bipolar leads, let's see. Bipolar leads are one negative and one positive. All right, electrode. So leads 1, 2, and 3 are your bipolar limb leads. Okay, you can see on the graph here, lead 1, lead 2, and lead 3. So lead 1 is always going to show, or should always show, a positive deflection because it's going from a negative to a positive. Lead 2 should also show a positive deflection because it's going from a negative to a positive, right? So a positive or an upward deflection. And then lead 3 should also show let me see, positive deflection. No, yeah, positive deflection. I'm sorry, the left leg electrode is always positive, right arm electrode is always negative. But lead 3 will also show a positive deflection because it's also going from a negative to a positive. Okay. Now your augmented limb leads, they're 2 negative bipolar leads combined to create an axis. Okay. So your AVR, which is augmented voltage right arm, your AVL, which is augmented voltage left arm, and then AVF, which is your augmented voltage foot or floor, okay? Usually on the left leg, okay? These are augmented unipolar leads, and the A in ABR, ABL, ABF represents augmented, whereas the V identifies it as unipolar, and the letter indicates where it's placed, right, left, or foot, okay? Precordial leads, they're placed across the surface of the chest to measure cardiac electrical activity on a horizontal axis. They are designated V1 through V6. There, you can see. So this would be a typical placement for 12 lead or your precordial leads. If you want to get a look further on the right side of the heart, you place it as you see in the picture here, okay? And then you can get more of a posterior view by placing leads on the back, as you can see here. All right. Most commonly used lead is lead 2. The heart's electrical current flows toward its positive axis, giving it the best view. The positive lead is placed at the apex of the heart of the chest wall with the negative electrode below the right clavicle and the ground on the left side, okay? All right, ECG graph paper. Paper moves across the stylus at about 25 millimeters per second. This graph is divided by heavy and light lines. The light lines are 1 millimeter apart. Heavy lines are 5 millimeters apart, and heavy lines enclose large squares containing 25 smaller squares. Okay, so one box equals 0.04 seconds. One large box equals 0.2 seconds. The vertical axis reflects amplitude in millivolts, and so 2 large boxes equals 1 millivolt. Markings at the top are placed at 3 second intervals, so 15 large boxes to measure heart rate. All right, waveforms and complexes. We've got P wave, QRS waves, T waves. Technically, there's a U wave, which comes just after the T wave, but we're not really going to get into it. And then there's different segments. Okay, you have your PR segment, you have your ST segment, you have your R to R intervals, you have your QRS duration, you have your QT interval. And we'll talk about a little bit about those things. So the P wave is the first component and corresponds to atrial depolarization. QRS complex reflects ventricular depolarization, and then the T wave reflects repolarization of the ventricles. Briefly, real quick about the U wave. It occurs occasionally, and it may be associated with some sort of electrolyte abnormality, or could be a normal finding. So it's kind of irrelevant at this point. PR intervals, distance from the beginning of the P wave to the QRS complex, and it represents the time it takes for the impulse to travel from the atria to the ventricles, normally between 0.12 and 0.20 seconds. QRS interval is the distance from the first deflection to the last. It represents ventricular depolarization time. So this is usually between 0.04 and 0.12 seconds. And the ST segment is the distance from the S wave to the beginning of the T wave, and it may be elevated or depressed in certain disease states. Okay, usually an isolated electric line, ischemia causes ST depression or inverted T waves. And then the appearance of a Q wave can indicate infarction, usually past or previous damage, right? If somebody had a heart attack and they have part of the heart muscle that has been infarcted, then that will show up as a pretty significant Q wave on the EKG, okay? Talk about segments. Let's see. All right, so when we're looking at rhythms and EKGs, we want to know what normal looks like. Okay, we have to know what normal looks like, because if we're confident and we know exactly what normal is, then it's easy to determine what's not normal. Okay, that there's something wrong. If we're not really sure, confident what normal looks like, it's going to be really hard to look at a rhythm and determine that this is not normal, right? So we need to get really, really good at identifying and knowing the boundaries, the numbers, the image of what the waves look like, and again, like the corresponding numbers of the time that each wave should be, to really understand what normal is. Okay, once we have that foundation, then we can be able to identify what's abnormal. Okay, so I'd say there's a 5-step procedure to analyze rhythms. First, we're going to analyze the rate. Okay, so bradycardia is less than 60 beats a minute. Tachycardia is greater than 100 beats per minute. Okay, next we're going to analyze the rhythm. All right, occasionally irregular affects only a few intervals. Regularly irregular maintains a pattern, and then irregularly irregular has no particular relationship. Okay. Next, we'll analyze the P waves. Are they even present? Are they regular? Is there a P wave for each QRS wave? Okay. Are they upright or are they inverted? Do they all look alike? Right? Is one kind of a shorter duration versus the next one's a lot taller? Okay. What do they look like compared to other ones? Next, we're going to analyze the QRS complex. Okay, do those all look alike? What is the QRS duration? Is there a QRS that's even, is there always a QRS that's present? Okay. The next thing that we would jump into would be rhythms, but we're going to get to that in a little bit. Right now, we're going to jump into acute coronary syndromes. So ACS, acute coronary syndromes. This is basically a term to describe a multitude of things or ailments to the heart. All right. Basically, it's anything that causes reduction in coronary artery blood flow. All right. So there's any sort of hindrance to blood that's oxygenating the cardiac muscle, okay, the myocytes. All right, so we're going to, it's anything that will cause myocardial ischemia, okay, which is basically lacking oxygen, to injury, which if there's not oxygen reintroduced in a timely, then it will go from ischemia to injury. So it's basically, it's stressed to now it's injured. And furthermore, if there is no intervention, then you have infarction or cell death, okay? And that's when we'll see ST segment deviation or eventually elevation, all right? Indicative changes, ECG findings that are seen in leads that look directly at the area fed by the blocked vessel. And then we're gonna look at reciprocal changes, right? So if we see either elevation or deviation in contingent leads, then we are going to look to see if there's any reciprocal changes. Okay, so that's looking at leads in the opposite of the affected area. All right. So indicative changes if you see deviation or elevation in, let's say, V2, okay, but nowhere else, it's something to be a little suspicious of. But if you see, if there's not elevation or deviation in V1 or V3, okay, contiguously, or we call it anatomically contiguous lead. If you don't see it in 2 of those or more, then it's not really something that we're going to be too concerned with. Okay, if we do see elevation or depression or deviation, whatever, in 2 anatomically contiguous leads, so let's say V1, V2, V2, V3, V5, V6, or V6 lead 1 and 2, then we're going to have a very high suspicion for MI. Okay. So another thing that we're going to look at too is we might see some depression, might see some elevation, but it also has to correspond with certain numbers, right? I know that in our protocols, if it's not greater than 1 millimeter, I believe, then we're not really, for elevation anyways, we're not going to really consider it much of anything. So here, ST segment depression of 0.5 millimeter or more in a patient who's experiencing an ACS is suggestive of ischemia. Okay, so ischemia is just, remember, it's the first phase before it becomes injured or dead. So it's stressing, it's gasping for air at this point. Okay. Let's see. Evidence of myocardial injury can be seen on ECG as ST segment elevation. Okay, so now it has gone beyond gasping for air. Now no air, and it's beginning to the process of dying. Okay, that cell is not dead yet, but it is dying. Okay, and that's what we call myocardial injury, and that's where we're going to see some ST segment elevation. Okay, that's that. Move into more of ACS here. Okay, and we'll get back into kind of got out of order here just by finishing that one PowerPoint and jumping to this next one. We'll get back to ST segment elevation, MI and stuff. But so what is ACS, or what are some of the illnesses that or issues that contribute to ACS? So you have arteriosclerosis and atherosclerosis. Okay, arteriosclerosis, that's a chronic disease of the arterial system that's characterized by the abnormal thickening and hardening of the vessel walls, usually by plaque. Okay. Well, or could be anything. That's more the general term, but more specifically, the atherosclerosis is a form of arteriosclerosis. This is the thickening and hardening of the vessel walls caused by the buildup of fat-like deposits or plaque. Okay. You have your lumen, which should be open and unobstructed, but eventually there can be some buildup of plaque. Okay, and even a little bit of buildup that's going to cause some decrease in blood flow. Right when it begins, it's not going to really do much of anything, but still, just it's common sense. If you even partially obstruct anything, it's going to eliminate the full potential of that path. Right. So if we have a fully unobstructed lumen, we'll say that's 100%. Even if you have a beginning a little bit of buildup of plaque, we're going to say that that's 98%. Okay. Usually that's not going to be enough to cause any issues. But the problem is that that process has started, and if it goes untreated, if it goes unrecognized, which it will most of the time at that level, at that stage, it's going to continue to build. Okay, 98% to 90% to 80% occlusion to 70% occlusion to 50% occlusion, all the way down to 10% or even a complete block. Okay, obviously that's when we're going to run into some major issues. So you can see here on the screen, kind of what I was talking about. Here's a normal artery or lumen, okay, 100%. This fatty streak right here, this would be that 98%. All right. And it continues, obstructing more of the lumen or the artery until eventually you get to the clinical phase here, which will create either an aneurysm and rupture, all right, or occlusion by a thrombosis. So that would be the blood's not able to flow quickly enough, and so there's blood that's not flowing and becoming stagnant, and when that happens, then blood clotting occurs. So you could have plaque plus a blood clot. Okay, that's what we call occlusion by thrombosis. Or you could have critical stenosis, okay, which is basically where the plaque completely obstructs the lumen itself. Okay, and you got to remember too, and we're talking about just the arteries here. Okay, and if we remember back to what we talked about a little while ago, arteries are under high pressure. Okay, it's not a low pressure like the venous system. It is high pressure. And so that's because things are under high pressure and want to keep moving and keep pumping. That's when you can have ruptures, okay, aneurysms that rupture. Now the artery is bleeding out, right? Here's another look at what we're talking about. So again, coronary artery obstruction. So if you have partial, like that 98% to maybe 80%, you're not going to really have too many clinical signs and symptoms. There's unstable angina, non-ST segment elevation, myocardial infarction, and could lead to sudden death. If there's complete obstruction, whether by thrombus or stenosis, then that's when you're going to see the markers on the ECG. Okay, you're going to have your ST elevation. So here you can see it shows a pretty good illustration of what this would look like. So this outer circle here, this is the zone of ischemia. All right, so this is the part of the muscle or the heart muscle that is gasping for air. Okay, it's lacking oxygen. All right, so it's stressed out. It's not feeling good. It's basically being choked out. Okay, so you're going to see some T-wave inversion and depression. If you go to the next circle, all right, if we didn't get or if that muscle didn't get oxygenated, didn't get the help it needed after a certain amount of time, then it moves into the injury phase right here. All right, so now you're going to start seeing ST segment elevation right here. All right. And then finally, zone of infarction, right? The cells are dead. All right, and they're not going to be, there's not going to be a Lazarus moment for these cells. They are dead. Once we see this, if they are having the MI right now, you will still see the ST segment elevation right here, but you're also going to see a Q wave right here. Okay. This is really indicative of already dead tissue. Okay. Sometimes when we run on a patient who's had a previous heart attack, let's say they're just having like a respiratory issue, but we know that they have cardiac problems, so we throw an EKG on them. We don't see any ST elevation. We don't see any T-wave inversion or depression, but we see like they have just normal sinus rhythm, but we do see significant Q waves here. Okay, that means, let's say we don't even know that they've had a heart attack at this point yet, and we're getting their history. Once we see this Q wave, we'll be like, hey, have you had a heart attack before? Oh yeah, I had a heart attack, a year ago and had 3 stents put in. And I'm like, all right, you can see that, all right. And if they tell you no, they're lying, because this is almost always synonymous with cell death or infarction. Okay. So ischemia, right? Increased oxygen demand with reduced oxygen supply. Here are some sites for inguinal pain, right? Chest, neck, left arm, upper abdomen, all kinds of different spots. There's 2 different types of angina. They're stable and unstable. So your stable angina, that's what people will experience first before they go into unstable angina. Stable angina usually won't occur unless there is some physical activity that has stimulated it. All right, it's increased the heart's need for oxygen. But typically, if they stop doing the strenuous activity, then the symptoms will relieve themselves after a few minutes, with or without maybe some nitro. Okay, move into unstable angina. This is the period after stable and before MI. This can occur. You're just laying down watching TV. You're not doing anything. You're not exerting any energy. You're not doing anything that's demanding more oxygen for the body. This can usually last for more than 10 minutes or more. And then you're going to have some chest discomfort, chest pain, maybe some difficulty breathing, some sweating, some nausea, certainly some syncope, some dysrhythmias. So unstable angina and instamy, those will occur when blood flow through a coronary artery is partially or intermittently blocked. It's really hard to determine if they're just having an instamy or if they're having just a UA, unstable angina episode, okay, because they are very different. One is basically ischemic, and the other one, they're having a heart attack. Okay, but the signs and symptoms that they're going to present are going to be basically identical, and it's going to be very hard to distinguish between the 2 of them. Both of them are grouped together as called non-ST elevation acute coronary syndromes, because ECG changes associated with these conditions usually include ST depression and T-wave inversion in the leads that face the affected area. Cardiac biomarkers are elevated when an infarction is present. So the main cardiac biomarker that will be looked at is troponin levels. There will not be an increase in troponin in ischemia or injury. Okay, only when infarction is present, when there's cell death, then that troponin enzyme is then created or released and then can be detected. Okay. So we know the myocardial infarction, that happens when blood flow to the heart muscle stops, okay, or is suddenly decreased vastly long enough to cause cell death, okay, and then, or necrosis of the myocardium. This chest pain is going to last more than 20 minutes. There's nothing that they can do that will make it feel better or feel worse. It's going to be constant. The discomfort is often diffuse and might be accompanied by sweat, diaphoresis, dyspnea, nausea, abdominal pain, or syncope. Progression of MI, patient evaluation. So two questions that we need to be asking when doing our initial patient evaluation. What is the likelihood that the patient's signs and symptoms represent an ACS? We're going to answer that. We'll have that answer questioned by getting a good history, as well as vital signs and coupling it all together. And then secondly, what is the likelihood of an adverse clinical outcome? All right, what is the likelihood that something bad could happen if it goes untreated? All right. Not all discomfort is cardiac related, right? We know that. There can be mimics, such as when you have just epigastric problems, okay? That can mimic chest pain. So it's super important to obtain an accurate history and get signs and symptoms, and as well as ECGs. It really encompasses getting the whole picture. We're putting together a puzzle, but we want to complete that puzzle by putting as many of the pieces together as we can to get the picture. Okay, we're not going to be able to get the picture if we just put one puzzle piece on the table. Right, we got to put a bunch of these pieces together so we actually see what the picture is. We may not have all the pieces of the puzzle. Okay, but we want to get as many as that we can, that we can actually kind of see what that picture is. All right. All right, so if we're going on a chest pain call, it's imperative that we obtain and review the first 12 lead within 10 minutes of patient contact. This is because we want to establish a baseline, all right, because we want to see where are they at right now, and then as we continue our care for the patient and on scene and also in transport to the hospital, we're going to be obtaining several more 12 leads, and we want to have a baseline so we can see, all right, is this progression, or is it getting better, or is it staying the same? Okay, so it's super important to get that 12 lead in less than 10 minutes of patient contact. All right, so remember, indicative changes are significant when they're seeing at least two contiguous leads. They're considered contiguous if they look at the same or adjacent areas of the heart, or they are numerically consecutive chest leads. Okay? Hyperacute T waves. The T waves are tall, positive, peaked, and broad-based. Often not observed because these ECG changes have typically resolved by the time the patient seeks medical assistance. This could also be a sign of hyperkalemia. ST segment changes, new horizontal or downsloping ST depression of 0.5 millimeters or more is highly suggestive of myocardial ischemia. I know the threshold that we look at is 1 millimeter and not 0.5. Oh, I'm sorry, that's for depression. Okay, so if we have elevation of 1 millimeter or more at the J point, then this is suggestive of injury. All right. And that's going to be in lead V2 and V3 for leads. Oh, I'm sorry. In all other leads other than V2 and V3, it'll be 1 millimeter or more. For leads V2 and V3, those two themselves, it's considered significant if the ST segment is elevated more than 2 millimeters or more in men that are older than 40 years, or elevated 1.5 millimeters or more in women. All right. We don't have the ability to test their blood for biomarkers, so troponin. Possible to do. All right, so here's your contiguous lead. So when you're looking at your 12 lead, the first thing you want to do is, and you want to get into a system that you regularly operate when you look at a 12 lead. Okay, you want to look at it the same way every single time. And so the way I do it, the way I was taught, the way I do it is the first thing I do is I look at inferior. So I look at lead 2, lead 3, and then AVF. Okay, and then I move over to septum, V1 and V2. Then I look at the anterior leads, V3 and V4. And then I look at the lateral leads, which is V5, V6, lead 1, and AVL. Okay, I go in that order. Let's see. So here's an ECG, a 12 lead of an anteroseptal infarction. So what does that tell us? That tells us that there's an infarction in the anterior and septal area of the heart. So the front area and the middle part of the heart. And so what are we looking at? We're looking at V1, okay? So V1 right here, looks like there's a little bit of elevation. V2, more elevation. V3, more elevation. V4, elevation, all right? Those are contiguous leads, all showing the same thing, okay? That would be considered anteroseptal infarction. So your lateral wall infarction, your lateral view, it's going to be V5, V6, lead 1, and AVL. Let's see if there's a picture. Here we go. So V5, V6. Okay, not much going on here. But you go look at lead 1, you have some elevation, and AVL, definitely some elevation. Okay, and then you can look at lead 3. In lead 2, 3, and AVF, you have some reciprocal changes, okay? And that's just gonna help secure your index of suspicion. Your inferior infarct, that's lead 2, lead 3, and AVF. Okay, you can see here, lead 2, lead 3, AVF, all have the tombstone look. And then also reciprocal changes in lead 1 and AVL, right? Kind of like we looked before when we had lateral. When we saw the elevation in lead 1 and AVL, we looked for reciprocal changes in 2, 3, and AVF, and we saw those. Same thing with inferior infarction. We have elevation in 2, 3, AVF, and the reciprocal changes would be in lead 1 and AVL. Here's the 15 lead ECG, inferior, lateral, posterior, and right ventricular AMI. This person's heart is very sick. Correct. Oops. Biomarkers, talk about that with troponin. We can't test for that, but the hospital will. All right, so what are we going to do? When we suspect somebody's having an ACS episode, I know you've probably heard time is money. Well, here we're going to talk about time is muscle, pertaining to the heart. With strokes, time is brain. So time is muscle. So time is very sensitive. We need to be acutely aware of that. First thing we want to do is make sure we stabilize ABCs, put them in a position of comfort. We're going to assess the vital signs, give oxygen if it's needed, if they're below 94%, get a really good history, get a good sense of what their pain or discomfort is. If there's no contraindications, give aspirin. We want to get a 12 lead in less than 10 minutes of patient contact. Go ahead and load them up. We're going to start IV and get them going, transporting to a hospital. If there is evidence of a STEMI, then we're going to alert the receiving hospital and begin completing the reperfusion checklist. I know that we are going to actually, our protocols, we're going to let dispatch know that we're going to be calling a STEMI alert, and then they'll be figuring out what the closest hospital is that's capable of handling this type of alert. And then we'll also call into that hospital and let them know that we're coming with a STEMI. All right. You can give nitro. Make sure blood pressure is greater than 90. If they have a suspected right-sided MI, we want to kind of stay away from giving nitro. Give morphine for pain, or we can give fentanyl or ketamine for our protocols. Aspirin. All right, that's it for ACS. Now, quickly, we're going to talk about Scarbosa's criteria. I'm not super strong on this, but I'll do my best. So, Scarbosa's criteria is, have you ever gone on a patient who has a pacemaker? They have chest pain. They have all the presentations of having a heart attack, right? They're diaphoretic. They're nauseous. Maybe they had a syncopal episode. They have chest pain that doesn't resolve at all. All the signs and symptoms of an MI, right? They've had a prior heart attack before, and you throw them on a 12 lead, and you're like, I don't know. All I see is a paced rhythm, which looks like a ventricle rhythm, right? I don't know. I've had those, and it kind of stresses me out. But Scarbosa's criteria was developed in an attempt to kind of bridge or help explain or determine if there's actually an MI going on. So I know that most of us learned, way back in 12 lead cardiology class in paramedic school, the importance of differentiating a STEMI from its various imposters, right? So you have like ectopic or paced beats, left ventricular hypertrophy, LVH, early repolarization, left bundle branch block, and so on. A lot of those things, they'll show up looking similar to a STEMI, right? They're called imposters. One thing that was stressed in those lessons is that diagnosis of anterior STEMI was impossible in the presence of left bundle branch block, and that a newly occurring left bundle branch block was a STEMI equivalent. Okay, I was taught that. I know that was taught across the board. That was science. Okay, turns out neither of those things is necessarily true. There was guidelines 2013 by AHA basically stated that a new or presumed left bundle branch blocks is no longer considered an indicator or equivalent of STEMI. And there's indeed a method to diagnose STEMI in the presence of a left bundle branch block. All right, so in the 90s, Dr. Elena Scarbosa, she developed a criteria for recognizing ischemia in the presence of left bundle branch block. The criteria is now widely accepted in clinical practice, and it might yield valuable clues, allowing the astute clinician to call for timely activation of the cath lab. All right. So Scarbosa's criteria, in simplest terms, relies on the presence of inappropriate concordance or excessive discordance. Okay, so normally in left bundle branch block, we'd expect the J point or the ST segment to move in opposite direction of the QRS complex, right? So in other words, in those leads where the QRS complex is normally a positive direction, the J point and the ST segment should be slightly below the isoelectric line, okay? And in those leads where the QRS is negative, so primarily V1 through V3, the J point and the ST segment should rise slightly above the isoelectric line. Okay, this is what we call discordance. Okay, move in opposite directions. And a small amount of discordance is appropriate and expected in left bundle branch block. Okay, and we can see that. Stand by. You see that right here. Actually, that's going to be more concordance, not discordance. Oh, this one shows discordance. Oh, right here. Okay, this one right here is discordant. All right. Now, when the EKG shows inappropriate concordance, and so the J point and ST segment elevation in the positive leads, and the J point and the ST segment depression and negative leads, if we see that, there's a 90% likelihood that the patient is actually having a STEMI. Okay. And the beat, let's see, on the left, so right here, you'll note inappropriate concordance in a lead with a positive deflection of the QRS. Okay, that would be Scarbosa criteria A. All right, and the beat on the, well, right here in the middle. Okay, that one right there, that you'll note the inappropriate concordance in a lead with a negative QRS. This is Scarbosa criteria B. And one thing we want to make note of is when we recognize inappropriate concordance, it's got to be greater than or equal to 1 millimeter. And if we see that, it's highly predictive of STEMI. Okay. Now, this beat right here, one on the far right, okay, this illustrates Scarbosa's criteria C. It's got to be greater than or equal to 5 millimeters to be considered excessive discordance. Okay, criteria C is the weakest criteria of the three and may indicate a STEMI only 50% of the time versus the others are 90% of the time. However, even lower sensitivity is still better than throwing up your hands and saying that it can't be done, right? So that's basically, in a nutshell, is your Scarbosa's criteria. All right. We're running quite a bit over. I'm going to skip over tachycardias, and we're going to briefly talk about some of the protocols that we have. So, protocols for heart-related issues begin on page 48, which is your 12-lead ECG. Let's bring that up there. So page 48 talks about when we're going to initiate a 12-lead. Okay. So our protocols say less than 5 minutes. I know I just talked about less than 10 minutes per that slideshow, but our protocols say let's get a 12-lead on under 5 minutes of patient contact. All right, so when do we do it? All right, here's all these different reasons why we want to put a begin an EKG, a 12-lead. Page 57 would be the next one. Talks about AFib and a flutter. I'm going to do that. Hang on a second. No, it's freezing up on me. All right, so come across somebody with AFib and a flutter. with RVR, rapid ventricular response, IV access, 12 lead. Let's get end tidal on them. If we recognize the AFib or A-flutter, then we're going to need to convert them. All right. So their blood pressure is over 90. We give them some fluid. Prior to cardizem administration, when we see a stable narrow complex that's irregular, greater than 110 beats per minute, we're going to give a slow IV push of cardizem, 10 to 20 milligrams. We can repeat after 5 minutes if the rate is still above 110. Next is bradycardia. So there's going to be all kinds of reasons for bradycardia. All right, so page 58 talks about what can we do. We can use atropine, or if it's resistant to atropine, then we can do transcutaneous pacing. We can also give epi push dose pressor. Okay. Next is going to be page 61. Is going to be your cardiac arrest protocol. All right, so here we're going to immediately get hands on the chest, begin CPR, 120 compressions a minute, allowing full recoil. After 2 minutes, we're going to do a pulse check. All right, if no pulse, we'll continue CPR. We'll attach defibrillator pads in the anterior posterior position. Then we'll go ahead and put an airway in. Excuse me. Monitor capnography, make sure that we've got good airflow. Start fluids. Consider endotracheal tube, tubing somebody. And then we're going to go through our H's and T's, try to find out what caused the cardiac arrest, and then see if we can intervene. For patients with high suspicion of hyperkalemia, so show like a wide complex PEA or renal failure, we need to be suspicious of metabolic problems, right? So we're going to give them some calcium and some sodium bicarb. All right, so when we do have them hooked up and we're looking at their rhythm, is it a shockable rhythm or is it not? All right, so we shock 2 rhythms. That'd be VFib and pulseless VTAC. Okay, if they're not neither one of those two, then we are not going to shock them. All right, first shock, this says 200 to 360 joules biphasic. We're going 360 all the way right off the bat. Immediately after we give that shock, we're going to get hands back on the chest for a round of chest compressions for 2 minutes. We'll give them epi. First round, 1 to 10,000, 1 milligram. Can repeat every 3 minutes, up to 3 milligrams total. Keep going until, can we shock or not shock? Either way, after 2 minutes, we're going to continue hands on the chest. If they are in a shockable rhythm, we'll say VFib or VTAC. Okay, we can give amiodarone, give 300 mgs the first time, then we can repeat 150 milligrams after that. We'll consider MAG if we recognize torsades, or if the VFib is refractory to amiodarone. If the patient converts to amiodarone, then we want to administer 150 milligrams of amiodarone over 10 minutes. So the way we're going to do that, we're going to mix it into a bag of 100 cc bag, which we have, and we're going to drip it over 10 minutes. Okay. Unshockable rhythm, so asystole PA, basically anything other than VF or VT that's not producing a pressure. Then we're just going to continue with chest compressions and then epi push dose pressor. Here's your H's and T's that we're going to consider and try to treat, right? Hypovolemia, hypoxia, acidosis, hydrogen ion, hyperkalemia, hypoglycemia, hypothermia, toxins, cardiac tamponade, tension pneumothorax, thrombosis, whether coronary or pulmonary, and then trauma, hypovolemia or increased intracranial pressure. Next would be cardiogenic shock. And then there's a chest pain protocol. All right, so what's causing the chest pain? We want to figure that out. Is it acute pericarditis or myocarditis? Is it aortic dissection? Is it pulmonary embolism? Is it esophageal rupture? Is it angina or MI, spontaneous pneumothorax? Either way, we're going to establish IV access, get our 12 lead, our baseline 12 lead, give them oxygen if they're less than 94%. Consider fluid boluses to maintain blood pressure of greater than 90. Obviously, if we see a STEMI on the 12 lead, we're going to notify dispatch in the accepting facility. If the EKG is normal, there's no indication to complete a 15. There's no indication to complete a 15 lead EKG. Let's see. If left bundle branch block, hypotension, cardiac ischemia symptoms, consider STEMI. But again, we're going to, if there is no left bundle branch block, then we're going to refer to scarbosis criteria, which that next point says, paced rhythms and left bundle branch blocks may be further delineated for STEMI criteria using modified scarbosis criteria. We'll give aspirin if not contraindicated. Nitro, we'll also give a pain reliever. So give morphine or fentanyl. Then we have CHF. So we'll look at CPAP to help them with their breathing if they're in distress moving into failure. Make sure that if we are going to CPAP them, that they do not have altered mental status. Make sure that they are able to still breathe on their own. Make sure that they're able to follow directions. Okay, do not get CPAP if they can't do any of those. Similarly, we're going to give aspirin, give nitro, possibly give epi. Hypertension crisis on page 76. There's a threshold here to give labetalol. And even then, we need to be careful when we give labetalol because we don't want to drop their pressure too much too quickly. But to consider pharmacological intervention, that threshold is systolic 210, diastolic 120. If we get that on the monitor, we need to confirm that manually. All right. If that's the case and they're symptomatic, we may administer labetalol 5 to 20 milligrams slow IV push. May repeat after 10 minutes. But basically, our goal is we don't want that 210 to drop to drop below 180 too quickly. Okay. Next will be LVAD device, left ventricular assist device. This is people have these. They're not really going to have a blood pressure. Okay. But if we auscultate the heart, you should hear a continuous hum sound, and that's the LVAD actually working, and it's just constantly moving blood through the heart, through the lungs, through the body. Next, on page 107 will be tachycardia protocols. Let's see here, 107. All right, so we're looking tachycardia, right? We're looking as the QRS complex. Are they narrow? Are they wide? Are they regular? Are they irregular? We may need to cardiovert them. synchronized cardiovert, that is. We don't want to shock them in the absolute refractory period. Okay, that can cause major problems. Are they narrow and regular? We're going to start synchronized cardioversion at 100 joules. If they're narrow and irregular, same thing. If they're wide and regular, we are going to start at 100. Everything's going to be at 100, but if they're wide and irregular, then that's when we're looking at VFib or VTAC, and we're just going to defibrillate them and not synchronize, not cardiovert them in the way that we would these other rhythms. All right, if none of these, let's evaluate the QRS duration. Okay, if it's really wide and the QRS is greater than 20 or 0.2 seconds, consider the toxicology or metabolic etiology. All right, so here we'll consider giving some calcium. We'll also consider giving some sodium. All right, because it might be a electrolyte imbalance. Is it a wide QRS between 0.12 and 0.2 seconds? Yes, then give amiodarone, but we're not going to just give them 300 like we would in cardiac arrest. Okay, in this case, we're going to give 150 milligrams. We're going to put it in a bag of 100 milliliters of normal saline, and then we're going to drip it over 10 minutes. Okay. If resistant to amiodarone, still stable with regular monomorphic rhythm, then we're going to use adenosine. It'd be 12 milligram rapid IV bolus with basically a saline flush behind it. This is not a slow push. It is you hook it up, you push it fast, you follow it up by a flush, push it through. Hopefully then they convert out of that rhythm into a normal sinus rhythm. Consider vagal maneuvers. So have them bear down or blow through like a really, really tiny straw. Again, if you see torsades, then we're going to give MAG, 2 grams IV, or IAO. Cardioversion, page 156. All right, so before we actually do a synchronized cardioversion and they are actually conscious, since we're going to be restarting their heart by shooting some electricity through them, we want to make sure that they are sedated. Okay, so we can either do that with etomidate or all of our favorite ketamine. Okay, we're going to snow them down. The great thing about ketamine is it's a dissociative, right? So when they are under that influence, they're basically dissociating from their body. Okay, we want to make them not be too aware of the procedure that we're going to start by hitting Control-Alt-Delete on their heart. Page 159 is defibrillation. All right, so we're going to go anterior, posterior. We may, if they're big enough, do anterior, posterior, and then also right and left side of the chest. As you can see here, here's placement. EKG 160, so this protocol tells you exactly where to place the leads and then what you're looking at. Okay. And then lastly, on page 195, $185, $195. I promise we're almost done here. 195 is going to be transcutaneous pacing. Transcutaneous pacing on page 195. Okay, so this is if they They are bradycardic, but also they have to be symptomatic. Okay, they have a hemodynamic status is poor. Okay, not just a bradycardic rate, because maybe their blood pressure is just fine, maybe they're asymptomatic, then we don't need to give them atropine or transcutaneous pace. Okay. And that's about it for cardiac protocols. If you don't know them, go through them, get to know them, and there you have it. That is down and dirty crash course in cardiology, and a little bit over the time that I was allowed, and I apologize for that. But that's all I got. TK?
Man, that was great. That was a lot of info. I think you covered everything though, so let's go ahead and take a 10-minute break, and we'll probably do environmental. But I'm gonna have a conversation with Chief before then. Thanks, Travis.
All right, you bet. Thank you.